Good morning, everyone, and good afternoon, and maybe good evening to some of you. We're just going to wait a few minutes to allow people to come in. Thank you for joining. Good morning again to everyone who is joining, and then good afternoon to those to the east of us. Thank you for joining. We're just going to start in another minute or so. I think we'll go ahead and get started. Good morning again to all who have joined, and thank you for coming today. It's my great pleasure to introduce Dr. Ramya Ramaswamy. She is the Lasker Clinical Research Scholar at the National Cancer Institute, where she serves in the HIV and AIDS malignancy branch. As a physician scientist, Dr. Ramaswamy is deeply engaged in advancing our understanding of cancer associated with HIV, with a particular focus in Kaposi sarcoma. As most of you know, KS remains the most common cancer among men with HIV globally. KS is particularly common in Africa and in South America, but there are over 3,000 cases annually in the United States, and incidence in the United States exceeds almost all other countries outside of Africa and South America. So it remains a large challenge here in the United States and certainly in other parts of the world. Dr. Ramaswamy's work spans both US and global settings and addresses challenges of cancer care in people with HIV through a combination of clinical research, translational science, and global collaboration. Today, she'll be sharing her insights into the biology of KS and KSHV and an exciting targeted treatment strategy that she and her colleagues at NCI have pioneered. Please join me in welcoming Dr. Ramya Ramaswamy. And throughout this webinar, you are able to pose questions in the chat or raise your hand. Dr. Ramaswamy asked to hold most questions till the end, but if there are clarifying points or things that you think should be mentioned in real time, please just raise your hand and we'll call on you. And I'll now turn it over to you, Ramya. Thank you so much.
Lovely. Thank you so much for that wonderful introduction, and very thankful for the invitation to speak with you all today. We are certainly all global collaborators in this condition, so it's a true delight to speak to kindred spirits. I consider myself an oncologist, but my spirit animal is certainly an infectious disease doctor, so it's wonderful to connect with you all today. So I just want to start quickly with my disclosures. I hope you can see my screen okay. Scott, everything looks good.
Yeah, we just see you.
Oh, you don't see my screen?
I can see the slides.
Oh, okay. Maybe my view is not correct.
Yeah.
Sorry.
So it looks great from my
Okay.
perspective. Yeah.
Okay, great. So I just want to mention briefly that I am a partner with participants in our studies, but we get a lot of our drug supply from collaborative agreements, CRADA, with companies. So you'll hear me mention a lot of the work done in our clinical trials, and these are the companies that we work with to get study medication for those clinical trials. So to get to where we are with the promises and future horizons, I want us to take a journey back 40 years ago. And the start of the understanding of KS in the current times takes us back to 1981, where the understanding of KS itself was one that it was seen predominantly among older Mediterranean men. But suddenly in 1981, it was a cancer that was seen among young gay men who were unfortunately dying of the cancer. and it was the harbinger of the HIV epidemic itself. In 1987, we, as a community of scientists in close collaboration with patient advocates in the HIV community, developed AZT, which was the first drug approved by the US FDA to treat HIV/AIDS. And it's important to, again, mention the role of HIV activists and the LGBTQ community that helped to contribute to the advances in understanding HIV at the time. And in 1994, we only identified KSHV as the cause of Kaposi sarcoma. And by this point, we had incremental advances in HIV management, but the understanding of KS itself was very limited. Was it actually a sexually transmitted disease, and what was the underlying cause? So it was the work of Chang and Moore, as well as Ethel Seserman, that led to the identification of Kaposi sarcoma herpes virus, or human herpes virus 8, a DNA virus that was noted in KS lesions among patients. And in 1995, it was the first drug that was actually used and approved for Kaposi sarcoma was liposomal doxorubicin, which is an IV anthracycline chemotherapy that was used in patients with KS. By 1997, we had a second drug for Kaposi sarcoma, paclitaxel, which is another IV chemotherapy infusional agent. It's a taxane. And we noted that by this point, although we had seen a spike in the incidence rates of Kaposi sarcoma, and this is a graph from San Francisco at the time, we did see a precipitous drop in cases with the advances of ART and the initiation of ART with HIV, an HIV diagnosis. But we also note that HIV itself is not a local problem, it is a global issue. And so we had increased awareness and an understanding to ensure that the education about HIV went to our partners in other parts of the world, specifically Sub-Saharan Africa. And so as we have come to this point, we now have a better understanding of KSHV itself, but we're still learning every day. On the left, you can see the virus, it's DNA virus, and the open reading frames that control and lead to the onset of disease. And I'll talk a little bit about that as we discuss and delve into the subject matter today. The virus itself is found in many parts of the world. Here is a map showing high areas of prevalence, particularly in Sub-Saharan Africa, the purple Central Africa, and we see within the United States high prevalence, particularly in the MSM population and particularly among the HIV positive population as well. And with regards to the treatments currently, there are 3 approved treatments for Kaposi sarcoma. The 2 that I mentioned earlier from 1995 and 97 are IV infusional chemotherapies. And most recently in 2020, our group was involved with the approval of pomalidomide, an oral drug for Kaposi sarcoma, which is still under investigation. Briefly about the virus itself, we haven't developed cures yet for KSHV or HHV8. We know that it's a virus that is latent in humans for a very long time, which means that it is highly persistent, and it has a tendency in its second program to replicate. And in the image in the middle, you can see many of the components that are used by the virus to replicate and control the functions within the host. So it has its own way of developing blood vessels and evading the immune system, and also has its own way of controlling mechanisms and molecular mimicry, such as controlling apoptosis. So it's a very highly complicated but very interesting virus, and I'll look forward to telling you more about the manifestations of this virus in people. So as we all know, the first condition that KSHV is associated with is Kaposi sarcoma. So it is an infection of endothelial cells, which are in all of us everywhere. And so usually, as you can see in this image here, we see manifestations of KS, a vascular tumor, predominantly in the lower limbs. So this image on the left is one of dark pigmentation on the skin and also on over the toe. Under the microscope, you see this section here where we see LANA positive cells, which is indicative of Kaposi sarcoma. As I mentioned, these lesions are predominantly on the skin, but we do see manifestations in advanced cases, both of pulmonary and gastrointestinal manifestations, and this can lead to highly symptomatic individuals with KS. It can occur at every CD4 count, even though at the beginning of the HIV epidemic, we often saw it associated with lower CD4 counts. KS can actually affect individuals at any CD4 count, especially in the current age. The second condition that's histologically associated with KSHV is Castleman disease, or MCD. Castleman disease, multicentric Castleman disease, is actually a condition consisting of several disorders. However, we know that among people with HIV, KSHV associated Castleman's is a distinct condition. It is it's caused by infection of KSHV of the B cells, and it's a lymphoproliferative disorder rather than, so it's a polyclonal process, infection of B cells that are polyclonal. And patients can often present with fevers, night sweats that are relapsing and remitting in their course. This condition actually, interestingly, tends to present at higher CD4 T cells among people with HIV. Lastly, among the histologically associated diseases with KSHV is primary effusion lymphoma, which is a non-Hodgkin lymphoma, B-cell lymphoma that's clonal in process. Primary effusion lymphoma being effusion, so fluid around within cavities. So you can see pleural effusions, ascites in patients. And under the microscope and cytology, you see these very typical abnormal lymphocytes that look like Pell cells. They're very few, but we're very lucky to have this image that shows these abnormal cells. And patients can be very unwell systemically with shortness of breath and profound symptoms associated with Pell. These do tend to occur at lower CD4 counts, and if you were to look this up on Google, you would see that the average life expectancy is low, but we treat patients here with curative intent, and over the last several years, we've seen median overall survival of this condition of almost over 2 years. So with an intent for curative treatment, this condition can be very well managed. So with that, I want to start us off with a case we all identify with patients and examples. So this is a sort of typical example of a patient who may come and see us in our clinic. So taking us back to 2017, we have a 28-year-old man who presents with a diagnosis of HIV. His CD4 T cells at the time are very low at 16. He starts his ART promptly, and very soon after, his HIV viral load is undetectable. In 2018, he presents with chaos of his skin with associated edema that impacts his quality of life. He remains adherent to his HIV therapy, and his CD4 T cells are now 140 cells per microliter. So at the time he presents with KS, because he is symptomatic, and the schema here shows the staging of KS, we know that he has edema, which does confer some poor risk. If he were to have visceral involvement with GI or pulmonary disease, we know that that would actually also be associated with poor risk. He has a low CD4 T cell count. And so he was started, this was while he was on the outside, started on liposomal doxorubicin. As we know, that is a standard treatment for KS. And we know that ART management in people with HIV who have KS is an essential part of their management for KS. So he continues on that. So based on his presentation, he started on chemotherapy. And so in 2018, he notes that after finishing his liposomal doxorubicin, and just in terms of principles of management of KS, even though cancer care sort of says a magic 6 cycles. We know that with managing KS, it's often until there's a plateau and excellent response in patients. This patient then has persistent KS, and so is switched by his oncologist to paclitaxel. We now know that's the second option for Kaposi sarcoma. By 2019, he notes worsening lymphedema and swelling associated with worsening lymphadenopathy or increase in his lymph nodes. He has a biopsy of those lymph nodes that shows KS. And because he's been on 2 of the 3 options, he starts pomalidomide for his management of KS. And shortly after 3 months, he stops due to worsening of his KS, but he does note improvement of his lymphadenopathy. Just as I mentioned, our group did publish on the use of pomalidomide in Kaposi sarcoma. It's an immunomodulatory drug that's actually approved for multiple myeloma. And we see a response rate overall among people with and without HIV of 71%. The median overall median progression-free survival for patients with KS is approximately 10 months. So it's not uncommon that we see that this individual has seen some worsening of his KS while he's been on pomalidomide. It is an excellent option with limited disease, but he has developed extensive KS. By 2020, he notes worsening, again, swelling, worsening lymphadenopathy, and his oncologist starts him on more liposomal doxorubicin, at which point he seeks our help at the NIH. So the patient that we've discussed is a typical patient that's seen in many clinics around the US and worldwide, where they're diagnosed with HIV and KS, and they're very adherent with their ART. And so start their chemotherapy, but soon after once there's a remission, they may have recurrent KS. And we know that you can still give more liposomal doxorubicin, and this may lead to remission, but there may be yet another case of KS within the same individual, which may prompt more chemotherapy and another different type of treatment. So this is typically what we see with KS management. And what we know is KS is a remitting and relapsing condition. As we discussed earlier, this is partly because we can't eradicate the virus itself. So many of our patients can, although very young, can go through life having several courses of chemotherapy. This can mean long-term toxicities. These drugs are not benign. They can develop cardiac toxicities long-term with anthracycline chemotherapy. Secondary malignancies are a risk. And these medications do have impact on CD4 T cells as well. And fundamentally, they don't necessarily all, and pomalidomide may address some of the viral etiology of KS, but certainly chemotherapy is not known to necessarily do that. So when we go back to our young man, by 2020, when he presents to our clinical center at the NIH, he reports extreme fatigue, shortness of breath, a lot of swelling and worsening KS. And you can see some of his KS images here on the right of your screen. He has an FDG PET scan and a biopsy of a lymph node in his arms show a diagnosis of Castleman disease. And so he initiates rituximab, which is an anti-CD20 monoclonal antibody, alongside his liposomal doxorubicin, and sees benefit. So I've mentioned the 3 histologic diagnoses that occur with KSHV, and here is a patient who has both KS and Castleman disease. I do want to mention a diagnosis of KICS, KSHV-associated inflammatory cytokine syndrome, which was identified by our group back in 2010 among 6 patients who were seen in the clinical center. This was actually an interesting phenomenon that was observed at the time because patients had a constellation of signs and symptoms that were very much seen in the same patient that we just discussed: fevers, night sweats, fatigue, worsening edema, inflammation, and elevated HHV, KSHV viral load. But they didn't have any evidence of MCD. And so there were specific KICS criteria that were developed to better understand this disease. And how we define KICS is the presence of at least 2 signs or symptoms from the first 3 boxes, as you can see. So either symptoms or lab findings or radiology findings that may be indicative of a KSHV-driven process with evidence of inflammation, elevated CRP, KSHV viral load, but no evidence of Castleman's. And more recently, we've extended this to include primary effusion lymphoma that also meets many of these criteria. So as a typical example of a patient with KICS, we may see someone who's diagnosed with HIV and KS, who may have a relatively low CD4 T cell count, started on ART, and is adherent on their ART, and by 6 months in is still reporting worsening KS, has interventions to look for PEL and MCD, and there's nothing but just worsening KS and inflammation. And this is typical of someone who develops KICS and KS at the same time. So it is very much a diagnosis of exclusion, looking for the other histologic diagnoses associated with KSHV. So even though we have one virus, they overlap. And I think that's one of the main key messages I want to get across to you today, is that this one virus with their overlapping manifestations, histologic diagnoses, and of course, KICS being a diagnosis of exclusion, results in 9 manifestations of the disease. So you can see a patient in the hospital with KS, worsening fevers and night sweats. There's a lot in a person with HIV that could account for that. But unless you look for these other conditions with imaging, with histologic analyses, you won't identify the concurrent KSHV associated diseases. And this has been the experience that we've had for the last few years here at the NCI, is that it's really honing in on the different histologic subtypes that are associated with KSHV that yields the diagnosis. And so I do want to mention our fantastic pathology colleagues who are based here at the NCI, who help us diagnose these diseases. And often patients are referred to us with what they are told is a diagnosis of KS, but we often identify and unveil other conditions in tandem. And I'm very excited that Dr. Hao-Wei Wang has actually developed an effusion-based analysis of to diagnose Castleman's in effusions, primarily because, as I mentioned earlier, Castleman's is a histologic diagnosis made from lymph node biopsies, but that can often be challenging because you can't sample every single lymph node in a patient with HIV. So his group, along with a collaboration with us, were able to develop a study looking at effusion-based analyses and identifying Castleman's that are lambda-restricted plasmablasts within effusions, which is extremely exciting and presents promises for limited resource settings. And again, going back to understanding the diagnoses that may be present, that impacts the disease manifestations and then the treatments that we can then provide to a patient. So identifying someone with Kaposi's, as we did, but then finding Castleman disease changes the management of that patient, adding a monoclonal antibody. If we identified lymphoma, we would then go for curative management with multi-agent anthracycline-based chemotherapy for lymphoma. In the cohorts that we've managed at the NCI, I know that in blood samples collected from many of the patients in our natural history studies, which are longitudinal analyses of these patients over time, we know that certain cytokines such as IL-6 and IL-10 are elevated when patients have concurrent KICS, MCD, or PEL and/or PEL. And so what we know is that the elevation of these cytokines actually in PEL are associated with worse outcomes. We also know that compared to KS, that they're very much elevated, and this actually does impact outcome. This is a analysis of our patients in our KICS protocol as compared with patients with other KSHV-associated diseases. And in yellow, we see that patients with KS have an excellent overall survival, very different from patients who have PEL in KS and MCD in KS or KICS in KS. So it tells you that KS may be something that you see and is so visual, but unless you dig deeper and look for these diseases, it can actually really impact the patient's outcome. So I know that it does all impact the survival of patients, but I do want to say that there are promising things on the horizon. Understanding the pathogenesis of these KSHV-associated diseases, why and how these cytokines, this dysregulation of cytokines occur in patients with concurrent KADs or KSHV-associated diseases can impact our understanding of how they emerge, but also how we can diagnose these diseases and how we can treat them, especially in resource-limited settings where they may be missed because of lack of expertise or a lack of the resources such as imaging, etc. I'm very lucky here that we work with an excellent group of colleagues over at Frederick National Laboratory, Denise Whitby and her colleagues who do a lot of work in Uganda as well, understanding the role of the virus KSHV and how it affects people both with and without KSHV-associated diseases. So we work with them to understand how KSHV develops and manifests in patients with diseases over time in many bodily fluids ranging from saliva to blood, and see how this can help us better diagnose and treat patients. So I want to move over in our time together to understand a little more about the novel therapies for KS. So our focus in our group, as we did with pomalidomide, is start to really look at chemotherapy sparing options and specifically target some of the aspects of KSHV pathogenesis, and then look at how these individuals who are treated on these studies can help inform us of how the virus and how the virus affects the host, the patient with KSHV-associated disease, and how the treatment may impact that over time. So this is an image of a young man who we've seen in the last 5 years. So when people tell us that does KS still exist in the United States, it very much does. We in Bethesda here in Maryland are very close to DC, and it is one of the centers where we do see a lot of new HIV diagnoses in the area. So we are still very much managing Kaposi sarcoma 40 years from some of the first cases among people with HIV. So again, just to reiterate, the virus has 2 programs, latency and lytic activation. In latency, it's expressing very few genes that allow for persistence. And when the virus is actively replicating in its lytic phase, it's expressing all the elements of the open reading frames of the virus. And again, it's interesting to note that it has its own molecular mimicry, which includes things like viral cyclins, its own anti-angiogenic properties, pro-angiogenic properties. So specifically thinking about cell cycle dysregulation, we know that it's a hallmark of cancer, and we know that cell cycle dysregulation leads to sustained cellular proliferation. And cyclins and cyclin D kinases, as you can see in the schema, are essential in regulating the cell cycle. And CDK4/6 inhibitors, which are highlighted here, are noted to inhibit the CDK cyclin D complex, which blocks the phosphorylation of the retinoblastoma tumor suppressor protein. And that actually leads to the prevention of proliferation of cancer cells themselves. So these are the CDK4/6 inhibitors are oral agents, and they consist of palbociclib, ribociclib, and abemaciclib. They've actually been very well studied in patients who have breast cancer, and it's actually approved first line in metastatic breast cancer. Very well profiled adverse events, which include diarrhea, neutropenia, and they're given orally twice a day in most patients, and in patients with breast cancer, they're combined with anti-estrogen therapy. So looking specifically at how CDK inhibitors affect KSHV infection, there's actually been a lot of preclinical studies looking at this. The first is a genome-wide CRISPR-Cas9 knockout screen of KSHV-infected B cell lines. And this highlighted CCND2, which codes a G1S specific cyclin D2. And this was actually ranked as one of the top genes in the cell lines that the cell lines were actually dependent on. So palbociclib in this model was highly effective in controlling proliferation of PAL cell lines. One thing to note in our field is we still struggle a lot with modeling Kaposi sarcoma, and there's a lot of reliance on KSHV-infected B cells or endothelial cells in culture. There are very few models that help us emulate what happens in patients, unlike other cancer types. A second a study that highlighted the important role of viral cyclin, as I mentioned earlier, which is a homologue of human cyclin, expresses latency in conjunction with the CDK6 compound, and that can actually modulate cellular proliferation in PAL cells. And finally, closer to the NCI within our branch, Dr. Yarshwin, who's our branch chief, led a study looking at CDK4/6 inhibitors such as abemaciclib, which inhibited cell growth and increased expression of immune cell surface markers in KSHV, again, KSHV-infected B cell lines and endothelial cell lines, indicating that this drug may be effective or helpful in KSHV-associated disease and accentuating the immune system to better identify and treat and kill some of these KSHV-infected cells. So based on this preclinical data, we developed a study looking at abemaciclib, which is the most recent, one of the most recently used CDK4/6 inhibitors in breast cancer. And the first phase of the study was to look at the safety and tolerability of abemaciclib in KS. And in the second phase, we looked at the response rate of this drug in KS. So in terms of eligibility criteria, we had adults over 18 years of age. For people with HIV, they were required to have at least 8 weeks of ART to ensure we understood the effects of abemaciclib. It does interact with CYP3A4 inhibitors, so we're mindful of any participants who have boosted regimens. We routinely request our pharmacists to review medications prior to study initiation. There was no CD4 T cell count or HIV viral load threshold for study entry. This is an important point to ensure that participants with HIV don't have any barriers to cancer care as they enter clinical trials. We required at least 5 lesions on the skin for assessment by the ACTG criteria, and we required a washout of 3 weeks prior to the study entry. So just briefly to reiterate, we started on the FDA-approved dose of 200 milligrams twice a day of abemaciclib. It's a 3+3 dose de-escalation, so we started off with 3 participants. They actually all did very well, so we actually just allowed for expansion to 6 participants to evaluate for response. We then, in the second phase, so the first phase, all participants had to have had prior KS treatment. So again, Doxil, liposomal doxorubicin, paclitaxel, and or pomalidomide. So have some form of standard treatment. ART, of course, was essential. In the second phase, we included participants who had prior KS therapy, but we also had a phase where we had participants with no prior KS therapy. So if they had HIV, they just were on ART and they'd never seen another systemic treatment for their KS. So I'm pleased to say that we've actually enrolled all the participants in the study, and 31 have been evaluable. A little bit about the participants. Most of them were male, and we see this as a demographic feature among patients with KS in the US, as most of our participants are male. We had a diverse population representation. The median age was 44 years. We actually had a lot of participants who had stage T1 disease. So as you recall, that's the evidence of edema. but 10 of these individuals also had the presence of visceral involvement, so either GI or pulmonary disease. Most of our participants, so of the 34, sorry, 25 had a history of HIV. Most of them had actually been on, even though we required 8 weeks prior to study entry, they'd actually been on ART for a very long time, had robust CD4 T cell counts, and an undetectable HIV viral load. In terms of adverse events, we actually saw a similar profile to what we expected with our data from the breast cancer community. We did see a high prevalence of neutropenia, a drop in the neutrophil count, which was managed with either dose delays or administration of growth factor support. In some patients, because we were able to drop the dose if there were inter-participant dose reductions that were feasible, we went down from 200 twice a day to 150. So 13 participants required dose reductions in that way. One of the most common side effects of abemaciclib is diarrhea. So we did see diarrhea as very limited but managed diarrhea in participants. And we saw creatinine increases in a lot of patients as well, which again is an expected side effect, but doesn't actually affect function of the kidneys and resolves after cessation of the drug. So again, we saw an adverse event profile that was consistent with other classes of the same agent. So in terms of the KAS responses on the study, we have, this is a waterfall plot that shows the percentage change in the nodular lesions, which are thought to be the most aggressive of lesions from the time of baseline to during the treatment. So a 50% or more decrease from baseline is considered a partial response per the ACTG criteria. And as an oncologist, you kind of dream about good waterfall plots. So we did see an excellent outcome in 81% of our participants, where we saw at least a 50% or more decrease in some of the more aggressive KAS lesions. And it's important to note that our wonderful research nurse colleagues count and measure these KAS lesions every month. So there's a very close monitoring of the KAS lesions over time. In the red, you can see the patients who'd had prior therapy, and the response was pretty ubiquitous, including in those who had had no prior KAS treatment in blue. And in the gray dots there, you can see those who were HIV negative in the study. And it's impressive to see that in those who had had no prior systemic therapy and only had the ART if they were positive with HIV, we saw a response rate of over 90%. So I want to highlight the a specific participant response. We had a 23-year-old man who had had a year of HIV, and he had had excellent HIV therapy adherence. He had a CD4 T cell at presentation of 147 cells per microliter. And interestingly, he actually had onset of KAS following treatment for primary mediastinal B-cell lymphoma. So he'd had a lymphoma and multi-agent chemotherapy for his lymphoma and then developed KAS, which is, it's pretty common. That can happen. You're having immune suppression on immune suppression. And this individual presented with ophthalmic KAS manifestations. You can see the reddening around his eye. So he had conjunctival disease. And he also had rectal KAS, so had bleeding at presentation, and the cutaneous KAS that you can see on his skin. Following treatment, we saw that his eye was now normal, his skin lightened up, and you can see resolution of his mouth lesions. And he had complete improvement of his rectal bleeding, so had an excellent response to his KAS. So thinking a little bit about the effects of this treatment, particularly in people with HIV, as I mentioned earlier, we're interested to know how it affects the CD4 T cell counts. And I'm pleased to say this is preliminary data on our current participants, who are still, many of whom are still undergoing treatment. We did not see a decrease in CD4 T cells over time. If anything, we've seen a slight increase from prior to this third cycle to the end of treatment. And again, this is preliminary, but we're hopeful that, the preservation of CD4 T cells over time itself may portend an overall good outcome for our patients as compared to to having chemotherapy repeatedly, which impacts outcomes. So one of the things that is particularly exciting is being able to determine how and why patients respond to treatments. And so we have a patient here who has had an excellent adherence to his HIV, a 5-year history of HIV. And he's someone who's been with us since his HIV diagnosis and KS diagnosis. And he's had multiple lines of prior chemotherapy and immunotherapy. And his CD4 T cells are excellent, but still keeps having KS. And so he was on the study, did very well. You can see on your screen his nodular KS lesions, which dissipate over time. But he did require dose reductions due to recurrent neutrophil decreases over the course of the study. We, in the study, actually built in biopsies over time. So we had a baseline biopsy and one prior to cycle 3. So you can see on the screen here evidence of LANA positive endothelial cells, which you now will know that that is evidence of KS. And then in prior to cycle 3, we see very little LANA positivity, showing that the KS lesions have actually resolved, even though this was a biopsy of something that looked like KS on the skin. So one of the things that we're able to do here at the NCI is look at very modern technology and how this applies to our disease. There's been very little sequencing done. We know excellent colleagues in the community have been trying to do bulk sequencing of KS, but and there's some recent studies going on about single cell evaluation of KS lesions. And so using the FFPE tissues, the fixed tissues of KS lesions in our participants in the study over time. We applied this to a Visium HD technology, which is a high-resolution spatial transcriptomic technology that helps us identify the gene expression profile within the tumor sections, and in doing so in a spatial context. And we're able to actually look at RNA expression both of the host, but also able to incorporate some of the viral components, viral probes such as viral cyclins, some of the other viral homologs of human function within the tissue over time. So again, this is preliminary data, but you can see that in the pre-treatment image from this patient, the LANA positive areas are green. And we see actually looking at the cyclin D genes of the patient, very high expression pattern. So the dark green is indicative of that. And by the third, and we also see viral cyclin as well, which is very high, and evidence of that in the center of the specimen. But by cycle 3, we see very little LANA, actually no LANA, no evidence of cyclin D, and actually no evidence of viral cyclin. So we're still understanding and developing a sense of this technology and how it applies to KS. But it's exciting to see how this technology may help us understand why the drug is working in patients. So with regards to abemaciclib itself, I can say we have evidence of activity. We saw a response overall of 81%, and this is excellent. The response rates of standard agents range from about 50 to 70%. So this is an excellent response so far. We have seen the toxicity profile similar to the class of agents that have been used in patients with breast cancer, and they're manageable side effects with support from our study team. And we're excited about using technologies to better investigate the mechanism of action of abemaciclib and KS from our study participants. So the future, I think, is bright for understanding these diseases in our patients, and I'm very proud to work with Dr. Yarshwin and Dr. Lorraine, who we work together to understand these KSHV-associated diseases and conduct clinical trials in KS, Castleman's, as well as KICS, and our method is to collect samples over time during these studies to better understand the interaction between the virus, the immune system, and how the treatment affects these components. And so I want to thank our study team and our participants, primarily who are our partners in research. Specifically for the abemaciclib study, I want to thank Anna Weidel, who's the research nurse leading that initiative, as well as Dr. Jose Mercado Matos, our oncology fellow, who's a promising horizon, as the talk is named, for these diseases and management of oncology in general. And I want to thank my colleagues in the Krug and Ziegelbauer labs, who are our virology colleagues, who help understand these diseases, and managing virus in cancer is never easy. So having excellent colleagues gives us the opportunity to do that. So with that, I want to thank you all for listening, and I'm happy to take questions, and I will open it up to the floor.
Wonderful. Thank you so much, Dr. Ramaswamy. And it's really fantastic to hear the science, but also to hear how comprehensive the evaluations of potential therapies are. And it's also great to hear what excellent care patients receive. So there are a number of questions in the chat, but I'm going to take the prerogative to ask the first question about the technology that you shared to assess the mechanism of action for new agents. And my question is, do you think that this could help us do better assessments in phase 2 clinical trials, so that we understand, by understanding the mechanism of action and seeing, no longer seeing any markers, can we more rapidly move candidates forward to phase 3 and clinical trials?
So you're saying, so there are questions more around, by understanding the mechanism, can we move things forward to further stages? Yeah, I think that would be an important goal. I think we have been very lucky that we have got treatments for KS, but I think part of the challenge is there's still a separation, I would like to say, unfortunate separation in terms of resource, what's available, and what the investments are. Drugs like abemaciclib, CDK4/6 are widely used in breast cancer. Can we use the same model for breast cancer as we can do in, say, Kaposi sarcoma? If they're licensed in other cancers, can we repurpose some of these medications for KS? And again, I'm very lucky to work with amazing colleagues who are looking at models. Laurie Krug is developing a PDX model for KS, and this is exactly it, using candidates in murine models, potentially using them in patients seeing benefit, and then moving them to broader phase studies. I think one of the challenges with KS is there's always hesitancy with phase 3, just because in the US it's considered a rare condition. It's not so in other parts of the world. So how do we balance the need for ensuring dissemination, but also maintaining the integrity of understanding the science? Can we get specimens over from those parts of the world that help us understand whether the drug is helpful and working in the same manner in those populations as well?
Great. So that's great to hear. It's also a call for more collaboration. I'll take one of the questions here in the chat from David Spencer, and he asked, KS historically has been an AIDS-defining condition. Is it a complication of long-term survivors? Is it only seen in patients with persistently low CD4 counts?
Yeah, there's been a lot of studies more recently from France, but also Toby Maurer published back in the early 2000s that KS by then was actually also being seen in higher CD4 T cells. So I think this association with low CD4 and KS onset is, I think, keeping us back a little and not helping us predict what's on the horizon. So we have patients who have had HIV for a very long time. There is a graying HIV epidemic that is on the horizon if it's not already started. These are individuals who are exposed to KSHV. So we now know that, KSHV and T cell senescence are also closely linked. So if you've had exposure, even if your CD4s are high, they may not be necessarily that potent in keeping away these infections. So I do think we may start to see more people who are older with HIV, who are very treatment experienced with their ART, develop KS over time. We have had patients who have come to clinic who are in their 60s and early 70s who've developed 1 or 2 KS lesions, who've had HIV for years, excellent CD4 T cells, and they're worried. They've seen their loved ones die in the early parts of the epidemic, and they often associate KS with death. And so it's really trying to start to change that paradigm that KS can happen at, higher CD4 T cells, and they can be managed. It's a manageable condition.
It's great. And it's true across the whole spectrum of disease that you showed us.
Yeah.
I'll hand over to Scott.
So Dr. K has his hand up, and I don't know if you're able to unmute, Dr. K. Can you give the
I
question?
think I can. Yeah, thanks.
Yeah,
Microphone
Dr.
here.
K.
Yeah, really nice talk, Ramya. It was great. I just had a couple questions. Have you tried the CDK inhibitor in PEL? And one other question is that it was really impressive when you showed prior to cycle 3 of the CDK inhibitor, you couldn't detect any viral gene expression. Have you looked whether the viral genome is still present at all, or it just turned on?
No, we have, so this one participant has had KS, who had KS at baseline, didn't have KS at cycle 3. Even though, again, looking in the eye, you biopsied something that looked like KS. There was actually no LANA in the sample. So I'd be curious to take a sample from someone who maybe had some residual LANA positivity in the sample to answer your question. So I don't know if it's a sampling issue versus whether something is specifically happening to the virus following CDK4/6 treatment. Yeah, it's a good question.
And how about PEL? Have you tried it in PEL at all?
Oh, yes. So with the PEL question, yes, we have given it to one participant who has had very relapse refractory PEL in their CSF. It maintained things for a little bit of time in their CSF as in it controlled disease, but then the disease did come back. But we haven't used it sort of in the frontline setting alongside multi-agent chemotherapy. Yeah.
Great, thank you.
Thank you.
There's a number of other questions in the chat. I'm just going to, Dr. Edwin Choi, who's an oncologist at Mass General, asks about KICS pathophysiology and how that's related to IRIS.
Yeah, it's a really good question. So IRIS, the definition of IRIS is, I think, again, as a diagnosis of exclusion, it's a little bit of a tough one. We assume, or still there's a lot of work that needs to be done, that KS-IRIS occurs in the context of, the first up to 12 weeks of ART. And a lot of these patients with KICS are actually occurring much later than the initial period of ART initiation. So we're looking at patients 10, 12, 24 months from an ART initiation time point, with persistent KSHV viremia, pancytopenia, and the presentation of inflammation. But I think it's important to be mindful that KS-IRIS kind of does exist, but it's also important to look for other pathologic processes, even if you think someone has KS-IRIS. So I wonder sometimes whether the KS-IRIS literature has, in fact, appropriately excluded things like PEL and Castleman's, because, again, these are diagnoses that are histologic, as opposed to KS-IRIS or KICS that are diagnoses of exclusion. So I think it's challenging, and parsing out the different entities is going to always be a little bit challenging to do.
Great, thank you. And Dr. Geraldina Dominguez, Felix leader at NCI, asks, as you follow the patients treated for 6 cycles with abemaciclib, what is your expectation of recurrence that will not be? Is it your expectation that the recurrence will not be an issue? Can you use the drug again if the KS comes back?
Yeah, thank you for the question, Geraldina. We have given the abema for up to 2 years for patients. The study doesn't specify the total number of cycles, so the longest participant has been on for 2 years. His KS has not yet come back for now. if it does come back, yes, we've had a couple of patients who they've had a lot of different options and they can't have immunotherapy. So we've reverted back to abemaciclib in those participants and it has helped them. So there is a possibility that, you know, it could help, much like Doxil or liposomal doxorubicin or paclitaxel does in the recurrent setting.
And then there's a question from Mark Siegel also around Iris, but asking specifically about ART regimens. Great talk. I noticed in your first case that the patient seemed to develop his cutaneous KS as part of an Iris syndrome, which I have seen with MCD, but not with cutaneous KS. How common is that? And is this being seen more commonly with INSTI-based regimens, integrase inhibitor-based?
Yeah, I think it's thanks, Mark. That's an excellent question. Again, I think I would revert back to making sure that in the context of KS Iris, we're not dealing with concurrent Castleman's or PAL. I think our conversations with our colleagues in the infectious disease community, sometimes that can be missed and unclear whether we're missing those histologic diagnoses. But with regards to your question on INSTIs, it's been a question that we've been wondering too, whether INSTIs do account for some element of additional inflammation that we didn't quite see when INSTIs weren't the first line for HIV management. And I think that's a very important question, but it would be hard to know how to best answer it in a population. But it's one to ask, yes.
And Sue Lee asks, KSHV encodes its own microRNAs, long non-coding RNAs and circular RNAs that are known to play critical roles in viral oncogenesis and life cycle. Are there any RNA-based therapeutics that show promise against KS or other KSHV-associated diseases?
Yeah, no, that's a very important question. Thank you for asking that. And I'm lucky to have my wonderful colleague, Dr. Ziegelbauer, next door, who works specifically on microRNAs and their role in KSHV-associated diseases. I don't think yet that we've developed RNA-based therapeutics, but it's something that I'm sure with his help is on the horizon for patients with these diseases.
Great.
Yeah, there's so many great questions. There's a very nice question about from the background from Quinn Wang. I'm curious about the prevalence rate of KSHV associated disease in KSHV infected groups. How likely does KHSV infection lead to disease?
Yeah, really cool question. Thank you for that. We know that I mean, the work that Denise Whitby has done in Uganda, so the prevalence in particularly high and highly endemic areas it's KSHV is very, very common, but you still do need the precipitating factor, some form of immune impact, whether that is an HIV diagnosis, you know, impact on T cell dysregulation. We've seen patients who are young, who don't have HIV, who have KSHV associated disease. They've had exposure clearly, but we've also diagnosed primary immune deficiencies in those patients. So clearly there's some other component that drives the onset of disease. You can exist with the virus for a while. So we're in the midst of trying to parse that out a little more in our clinical center here. Yeah, it's a great question.
Dr. Choi asked another question, and maybe I'll add mine in with it. He asked whether there's a role for maintenance chemotherapy who respond to Doxil or Taxol, but then keep relapsing, and like whether we should consider using CDK inhibitors in those sort of contexts.
Yes, I mean, I think I do wonder in patients with recurrent disease, whether you're again missing a lytically driven process like Castleman's or PAL. So we're always mindful in patients who keep having recurrent KS, have we missed a diagnosis of MCD or PAL or PAL that may drive the KS, which often it does. And once you treat those diseases, the KS actually improves a lot more. So in patients with recurrent KS, I'd be very mindful of other KSHV associated disease, but certainly rather than thinking about maintenance chemotherapy, yeah, you could think about other oral options for patients if they can manage that. Yeah.
I hope you can tell by just the overwhelming number of questions how enthusiastic we are for your work, and just what a pleasure it was to have you, and to also to see oncologists and ID physicians working so closely together. It's great.
Wonderful.
Thank you so much
Wonderful
for
to
your
collaborate.
Can I
for
ask you just one more question
today.
before we close, Ramya, about what
Yeah.
your group's next steps are with this particular drug and and publications of this work, and when we can start trying to
Yeah.
utilize what sounds like really exciting progress here. Thank you.
So Dr. Mercado Matos presented this work at CROI, so it should be published as part of the CROI abstract profile. And this will also be presented at ASCO 2025. So hopefully if we can attend. But we are all working hard to make sure that we have the data in manuscript form, hopefully for the end of the year, so it can be disseminated. And we look to our colleagues in the NCCN guidelines to, review the work and make sure it's viable for guidelines, so it gets accessed. But we're also looking to our colleagues in South Africa to see if, or in other parts of the world, to see if in places where this is licensed, it could be used as well. So the information's disseminated and used.
Wonderful. Thank you so much, Ramya.
Yeah, this was fun. Thank you so much for your time.
Fun
Lovely
for
to be with
me,
you.
has been for everyone else.
Yes,
Thank
really great. Thank you so much.
Thank you. Be well. Have a good day.
Okay.
Too.
Bye, everyone.